Move the topics. Now, last but not least, now I'm asking Professor Abdul Wadud sir to give his speech. He is a professor and head of the Department of the Cardiology in Dhaka Medical College and also president of the IPDI. Now I'm requesting Professor Wadud sir to present his case. Yes, sir.
Can you see my slides?
Visible.
Sir,
unmute yourself, sir.
Honorable chairpersons.
Yes, sir.
Respected panelists and honorable audience. Today, my topic is management of heart failure in valvular heart disease. We have had some beautiful lectures, and that has actually helped me to reduce to some extent what I'm going to say. Is valvular heart disease a matter of concern? Look at this. A 2018 meta-analysis and review of the different studies found that the weighted pooled prevalence of cardiovascular disease in adult Bangladeshi was 5%. That is regardless of the types of cardiovascular disease, gender, and geographical location. Now, in patients with suspected heart failure in the primary care setting, a large proportion of patients have important valvular heart disease that may remain unrecognized. Why it is a matter of concern? In a UK study, it was found that among almost 80,000 suspected cases of heart failure, around half of them have valvular heart disease, regardless of its severity and etiology. Again, when you consider the Euroheart study, Euroheart survey, they found the patients with moderate to severe native valvular heart disease, around 70% presented with heart failure symptoms. So valvular heart disease and heart failure goes hand in hand. And among the valvular heart diseases, aortic stenosis, which is about 15%, and mitral regurgitation, which is up to 50%, they represent the most frequent etiologies of severe native valvular heart disease that is frequently associated with congestive heart failure. Remember that this is related to both degenerative, rheumatic, and also due to this dilated cardiomyopathy-related regurgitation or stenosis. So what guidelines say? They say valvular heart disease may cause or aggravate heart failure. Patient may have heart failure due to ischemic origin, later develop mitral regurgitation, that's a ischemic valvular heart disease, and that lead to aggravation of the heart failure. And patients with heart failure and concomitant valvular heart disease, they constitute a very high risk population. And guidelines suggest all of these patients should receive optimal medical therapy, of which we have heard previous 3 lectures, which has suggested what medical therapy should be given to these patients. But we should tailor them according to particular valvular lesion. Just a few terms which are important when you consider valvular heart disease. Preload, the volume of blood in ventricle at the end of diastole and related to the end-diastolic pressure. And afterload, the resistance the left ventricle must overcome to circulate the blood, to push the blood across the aortic valve into the aorta. Ventricular remodeling, for example, on the left side, the slide shows actually a very hypertrophic ventricle that may be related to an aortic stenosis. On the right slide, there is a dilated ventricle that may be related to a regurgitated lesion. Again, that remodeling, the term has been quite well explained in the previous lectures. Let's say a patient have an MI. There will be an expansion of infarct from hours to days if we cannot do the primary PCI in time. And gradually, there will be healing, scarring, dilatation, there will be global remodeling, and that will lead to dilated heart, annular dilatation, and malposition of the mitral valve cusp and regurgitation. We'll have ischemic MR. And ejection fraction, which is a very important factor regarding the prognosis. And that defines what we call the three tiers of heart failure. The heart failure with reduced ejection fraction, or the mid-range ejection fraction, or the preserved ejection fraction. And now we are also considering the, what we should say, the recovered heart failure patients. Now, what do we have regarding the valvular heart disease? These stages are similar to, as a whole, the whole heart failure patients. Stage A is at-risk patient who have risk factors for development of valvular heart disease. For example, a patient who has history of rheumatic fever. If you do not give prophylaxis, subsequent rheumatic fever will develop into rheumatic heart disease. Or a patient who has bicuspid aortic valve. He will, in his midlife, may develop bicuspid valve degeneration and then regurgitation or stenosis. Progressive heart failure, we have progressive valvular heart disease, mild to moderate severity and asymptomatic still now, but if we do the echo, we find that the patient have disease. Asymptomatic severe, these are two groups. The patient who met the criteria for severe valvular heart disease, particularly in echo or by care, but they see one in whom the left or right ventricle still remain compensated, and C2, the left or right ventricle is getting dilated, but still they are not that symptomatic. And the stage D, symptomatic patient, the patient who develops symptoms as a result of severe valvular heart disease. And how do we evaluate these patients? All patients with known and suspected valve disease, we should have a good history and physical examination to establish the symptom severity, the comorbidities that are present, the presence of the valve disease, the presence of heart failure, that we should establish. Now, ECG, the bedside test, which establishes the rhythm, probability the LV function, and presence or absence of chamber enlargement. Chest X-ray, particularly important in symptomatic patients, establishes the heart size, presence or absence of pulmonary vascular congestion or intrinsic lung disease. Also helps in, it shows calcification of the aorta and pericardium. Transthoracic echo, it's the foundation of actually evaluating the valvular heart disease. It establishes the chamber size and function, the valve morphology and severity and type of lesion, and the effect on pulmonary and systemic circulation. In selective cases, we can go for transesophageal echo. It provides high-quality assessment of mitral and particularly of prosthetic valve, including definition of intracardiac masses and possible associated abnormality, particularly infective endocarditis, intracardiac abscess, LA thrombus, etc. Biomarkers like BNP or NT-proBNP actually provide indirect assessment of the filling pressure and of myocardial damage. Lab investigation are required to assess a patient in order to evaluate the patient's suitability for a particular therapy, to detect reversible and treatable causes of heart failure, and the comorbidities that can interfere with heart failure. What are those? We know the blood count, the renal function test, including electrolytes, the thyroid function, the glucose profile, the lipid profile, the iron profile, and sometimes the liver function test. Further diagnostic tests are required when the symptoms are equivocal or there is discrepancy between the examination and echocardiogram, or we want to have a further definition of heart disease, or we want to assess the response of the ventricles and pulmonary circulation to load and to exercise. We can do the cardiac MRI or the PET CT and stress testing. Now, in case of acute heart failure, the patient comes with shortness of breath and সোজা বাংলায় খাবি খাচ্ছে অক্সিজেনের জন্য. So in these cases, the monitoring of the SpO2 is class 1 recommendation. It's important. And in some cases, if we consider, we can do the ABG as well, arterial blood pressure analysis. So oxygen should be given to all those patients where SpO2 is less than 90%. Or if we do the ABG, the partial pressure of oxygen is less than 60 millimeter mercury. We shall try to give oxygen. If that doesn't improve the symptom, we can go for non-invasive ventilation like CPAP or BiPAP. Intubation only if the patient develops respiratory failure or we cannot correct the hypoxemia or hypercapnia with non-invasive ventilation. The diuretics for any patient with valvular heart failure or acute heart failure, loop diuretics are the basic therapy which should be given to every patient. And when we want to shift it to oral therapy, we should be taking care that with the dose and duration should be adjusted according to the patient's symptoms and clinical status. This is class 1 recommendation. The diuretic, particularly loop diuretic, do not improve the mortality, but they do give the symptomatic relief to the patient, and that's important. And we can combine that, the loop diuretic, with either spironolactone, MRA, eplerenone, or other, or also thiazide diuretic. Vasodilator is sometimes needed, provided the patient's systolic pressure is more than 90 millimeter of mercury. That's class 2A recommendation. But you should be taking care, the blood pressure it should be maintained. Inotropic agent can be used, dobutamine or dopamine, levosimendan or phosphodiesterase 3 inhibitors. And now the new kid in the block, we have heard the myosin activator, and they can be used. But inotropic agents are not recommended unless the patient is symptomatically hypotensive or hypoperfused, because they can lead to more arrhythmia and death. Vasopressor, norepinephrine is the drug of choice, and that should be given and to increase the blood pressure and provide vital organ perfusion. But the blood pressure should be monitored closely in those cases. Thromboembolism prophylaxis should be given in acute valvular heart failure from the very beginning. We can use deoxin or beta blocker, class 2A recommendation in appropriate cases. So a specific recommendation is actually for surgical recommendation. I will take 2 minutes. In severe aortic stenosis, symptomatic patient, we have to go for surgery. That's quite all right. The problem is the patient is low flow, low gradient, where we have to use the low dose dopamine stress echocardiography to decide about the treatment. If the mean gradient is more than 40 millimeter of mercury, there is theoretically no lower LVEF where we can decide and go for AVR. For TAVI is recommended in high risk patient or where assessed by a heart team. Also in some cases where the surgery is possible, but still because of the high risk, the heart team can decide that TAVI is appropriate in these cases. And long-term results so far are good. In aortic regurgitation in all symptomatic patients and in asymptomatic patients with resting EF less than 50% should be referred for surgery. This algorithm is simple. If you have AR and with significant enlargement of ascending aorta, go for surgery. If you have symptoms, go for surgery. If you are not symptomless, but the LVEF is less than 50% or LV is quite dilated, go for surgery. Otherwise, we can go for medical treatment and wait, closely follow up for surgery in future. For MR, with the MR severity should be assessed according to SSAHA classification. And primary MR, mitral regurgitation surgery is indicated all symptomatic patients. But unlike the aortic regurgitation or aortic stenosis, if the EF is low, here surgical risk is quite high. And durable surgical repair may improve symptoms, although its effect on survival is unknown. Secondary mitral regurgitation occurs because of LV enlargement and remodeling, leading to reduced leaflet closure. Here, effective medical therapy, including CRT, may lead to reverse remodeling, and sometimes LV may be getting smaller and the functional MR may get well. But otherwise, we should consider surgery, particularly when the patient can undergo both bypass and valve repair or surgery together. Only pure isolated mitral valve surgery is questionable. But here, there may be percutaneous mitral valve intervention may be tried. 2 large studies that were published in 2018. MITRA-FR could not show any benefit in percutaneous mitral valve repair, but COAP showed there is encouraging result. The difference is that in COAP, the patient had to undergo extensive medical therapy, guideline recommended therapy, and only then they were taken for surgery. Tricuspid addition is secondary, may need surgical intervention while we are treating the other valves. And in case of Mitford as medical therapy, loop diuretics and high-dose MRA are used to reduce the peripheral edema, hepatic condition, secondary hyperaldosteronism. This is the summary of those recommendations. And we should consider thromboembolic prophylaxis in all symptomatic heart failure patients. But remember that NOAC treatment is contraindicated in patients with mechanical valve or at least moderate mitral stenosis. But we should not forget a non-pharmacological intervention. The heart failure patient should receive specific education to facilitate heart failure self-care, particularly in a heart failure clinic. Avoidance of excess fluid, sodium restriction, regular exercise, reduction of weight, all are important. And please never forget the comorbidities. So correction of anemia or control of diabetes or the CKD treatment, thyroid dysfunction, sleep apnea syndrome, all this should be treated when we consider the treatment of heart failure due to valvular heart disease. Thank you, dear audience. Thank you for your patient hearing.
Sir, for your brilliant deliberation. Now the session is open for the question answer. There is a question in chat box, that is heart failure with mid-range ejection fraction and heart failure with recovered ejection fraction absolutely same? Probably the question is towards Professor Abdul Kader Akando, sir. Am I audible?
Mid-range ejection fraction is the established class of heart failure, and recovery of the ejection fraction is another group where there is improvement of the left ventricular function. So the improved ejection fraction may be above 50, it may be above 40, even it may be below 40. Suppose if the ejection fraction is 20% at the baseline, if that ejection fraction is more than 30, that is also recovered ejection fraction. So by definition, the recovered ejection fraction is not the single digit for the diagnosis. You have to have the baseline data and follow-up data. If the follow-up data shows the ejection fraction improved more than 10%, then it is recovered ejection fraction. Is it clear?
Sir. Sir, there are no other questions